Okay, so good afternoon. Welcome all of you for this instruction course, which is measuring and monitoring way to improving quality of cataract surgery. So as we all know, so anything you want to improve, you have to measure. Without measuring, you will not be able to improve it. You will not know whether there is an improvement or a deterioration. So in that way, it becomes very important. Can I have the first slide? Okay. So I mean, any organization has only one challenge in building their practice. Now, everybody who starts a practice, they all have one challenge. What is it they want to have? Anyone who's starting a practice, what is it they are interested? There's only one thing you want to say. What is it? Number of cataract surgeries. More patients. So it's basically about how do you grow the volume of the patients. It's always important. So, because the reason being, every year your cost is going to increase, your expenses is going to increase. You cannot compensate that by charging the patients. No, if the patient volume is the same, you cannot just increase the charges by 10% or 15%. Every year you cannot do it. Only by volume you will be able to negate that. But even that growing has to happen in a very sustainable way. It should not be in an unsustainable way. So what is sustainable way is also about creating access, making the care affordable to the patient, and also you have to ensure quality. The quality becomes very, very important. I just want to share this one particular study done by an insurance company in America. And they asked their insurance, the people who have all paid the insurance, taken insurance, they send them a survey asking them, so if you want to choose a provider for your healthcare, whom do you consult? And you may consult many people, but you can give any number of people, but you can say whether they are very believable, somewhat believable, not believable, or not at all believable. That's how you also have to categorize them. So this is the answer they got. So 50% of them said they'll consult their family and friends. 29% said that they'll consult the second bar is all about the doctors. The 19% is about their organization. The next 19% is the insurance companies. And if you see in the end, it's the newspapers, TV, and others. So people may not really believe that. Then they also asked whether if the information given, will you believe that? The people who said no, they'll ask the family and friends. They said 70% of them said, we'll just take their word, we'll not take another opinion. But when it came to the doctor, the second one is the doctor, their family doctor. Even there, they said 30% only said they'll believe what the doctor said. So they'll probably take somebody else's opinion as well. So the word of mouth is very, very important. So when here, it's the family and friends or the people who had come to a hospital, have experienced the services, and they are the people going back and saying that. So 70% of the patients come based on the previous patient's experience. So leveraging that word of mouth becomes very, very important. How do we leverage that? The word of mouth can be done only through quality. The quality, when we talk about, there are two broad aspects. One is a clinical quality. When we say clinical quality, it's about the medical care, what the doctor provides. The second is the nursing care, because ophthalmology is a teamwork. Doctor alone is not there. You have at least, even any practitioner who's got a reasonable surgical volume, will have about 8 to 10 people supporting him in various activities. Third is the outcome, what you have done and what is the results you are able to give. The second part, which is equally important, is the service quality, which is about pricing, the ambience and the facilities and the transparency. So this is the patient knows about the service quality part. They know the prices across the system. They know which place looks better, what are the facilities available in different places. So you have to keep it updated. Whereas the clinical quality patients do not know much, but you have the responsibility to provide the best for them. So I'll just give you an example you are able to see. So this is the cataract surgeries in India, which happened between 1985 to 2011. So can anyone say why it started increasing from the year 92, 93 onwards? The volume as after that, up to, I can even say, even if you go 10 years beyond 1985, even up to 1975, the volume were 1.3 million. Last year, India did about close to 8.5 million cataract surgeries. But when you talked about 82, 83, it was only 1.2 millions. So the intraocular lens surgery. So when the intraocular lens surgery, why did the volume go up? Okay, results were better. Then what made the results get more patients? Active? Early detection of cataract. So the patients have to come seeking treatment, isn't it? So it's not just only the patient, the doctors also changed. Okay, in the sense, till 91, 92, when we were doing only intracapsular cataract extraction with a pair of glasses, we were only selecting patients who were blind, patients who had a 1 meter vision, 2 meter vision, or FCF. That's what we operate. Because even after surgery, the patient is going to see only 1/60 without an IOL inside. So they need to wear a glass to see the distance. So when you put an IOL and you are able to give the patient able to see 2 or 3 lines without the glasses, then your threshold for advising surgery suddenly went from almost perception of light 1 meter to 6/36, 6/24. So so what I'm telling is the quality. So when you are able to provide a better quality, not only the patients change, you also change. You also have a belief that I can do that patient, give them a much better vision. Earlier we thought, even if somebody is 660, will never operate. So those are the days we used to prescribe homatropine eye drops or phenylephrine eye drops so that people can dilate and they can see better. There are many patients, your drivers who got a posterior subcapsular cataract with 6/9 vision, we give them homatropine, allow them to drive. So now that IOL made a huge change, not just for the patient, but also the doctors. And again, what also made the volume go up is the support from the government. When you talk about 99, 2000, government also said, anybody who's doing a cataract surgery free, we will pay you certain amount of money. So that again, making it the quality, making it affordable is very important. That is not just for the country, but also for our thing. But we recently did a study looking at what is the pre-operative mean logMAR, visual acuity in the operated eyes. And we looked at 3 different categories. One is the patients from outreach. The second one is from subsidized, direct walk-in, free patient. Third is a paying patient. So why are we talking about this? Because we said, when we are going to do IOL surgery, we are going to increase the threshold of people with poor vision to come to the hospital. They'll come much earlier. That is our assumption. That is what we are testing here. So if you take the patient from outreach eye camps who come, this is the data from 2012 to 2023. The patients had, in the year 2012, the mean, the visual acuity was only 2/60. And the 2023, it has come down to 4, it has improved to 4/60. So that is all the progress we have made. That's a mean. And if you see the direct walk-in free patients, they are better. So even in 2012, they had a much better vision than people coming from the eye camp. Okay, and if you see, it took a huge hit during the period of COVID in 2020. Again, it went back. Only people with a very advanced loss of vision only came to the hospital. Now we have come back to the 2018 level last year. And the paying patient also, in 2012, it was like 5/60 or 6/60. In 2023, that also has come down to 23. So it may be, still there may be some quality issue for the patients to accept. Patients only when their vision is as poor as 6/60, they come. So this is a data that was taken from the RAB survey, which was done nationally. Recently, it was between 2017-18, this was done. When we say cataract surgical coverage at visual acuity of 3/60, the way it is calculated is the denominator or the patients who are in the community with cataract, and the vision is the better eye. The vision in the better eye is less than 3/60. Okay, the denominator is the patients in the whatever in the numerator. The numerator were the patients who had 3/60 or less with the cataract. The denominator is these patients plus all patients who have been operated for cataract in the community. If you see that, 92% of the patient is coverage is there. And if you take 6/60, it is 87%. When you look at less than 6/18, 6/24 or something, for all the patients who have got a cataract, plus you operated, the coverage is only 64%. The 1/3 of them remains. And when you go to 6/12, is what is being now recommended by the World Health Organization. Anybody vision is less than 6/12, it is advisable to operate them. There is a guideline. When you go there, only 50% have been operated. So you understand the volume of work that needs to be done outside, but you want to do operate on a patient with 6/12, you have to be really good. So understanding here, the understanding of the quality becomes very important. From being subjective, instead of saying, I do a good quality, you have to monitor the outcome for improvement. So you have to also analyze from that outcomes, and you have to adopt evidence-based practices, and you have to renew that. And I'll just introduce this quality pyramid for all of you. So when you talk about quality, quality has got 6 elements. The base of the pyramid is safety. On that only you have to have patient-centered practices or policies. Only on that you'll be able to build the efficiency, the effectiveness, and it also be a timely care and equity. The effectiveness, when we say it is about the visual outcome, it is about the complication. Efficiency is how much you are able to do with the given resources. So here we are going to talk about the first 3. Safety, patient-centeredness, and effectiveness is what we'll be covering in this particular instruction course. Dr. Haripriya will talk about the safety part. She will talk about how do we deliver safe cataract surgery. Dr. Shivakumar will talk about the effectiveness part, ensuring good visual outcomes. Dr. Venkatesh will talk about the patient-centered part, understanding patient expectation and monitoring the satisfaction. So with this introduction, now I call upon Dr. Haripriya to talk about delivering safe cataract surgery. Thank you. Dr. Haripriya is the Chief of Cataract Services at Aravind Hospital, Chennai. Thank you.
Thank you, sir, for this opportunity. So I'll be focusing on how do we deliver safe surgery, more specific to cataract. I have no financial disclosures to share. So we have spoken about the quality pyramid, and the safety is the most important, being in the base of the pyramid, which means trying to do no harm to the patient. So the whole goal is you want to help the patient have better outcome. So this is a very good publication looking at about 3.2 million surgeries published in JAMA, looked at surgeries done over 8 years. This is all different specialties in a veterans hospital. And here they reported that there were about 277 errors, and these included wrong side or wrong site or wrong implants. This is all different avenues of medicine. And of these, the top on the list was ophthalmology. So in ophthalmology, we have the highest risk of having surgery on a wrong patient or the wrong eye or the wrong power. This is also because of the laterality issue. And while it is about 1 in 20,000 procedures, in the rest of medicine, it's about 1 in 10,000 in ophthalmology. And the most common reason which has been mentioned is that there is issues in performing a comprehensive timeout. You must have, some of you may have read the book by Atul Gawande on Checklist Manifesto, where now it has become mandatory from the WHO that we administer a surgical safety checklist for all our patients, irrespective of whether it's a procedure or a surgery. And this has proven to be beneficial in the aviation industry, and it's now a mandate. We do it for every procedure and every surgery. So in Aravind, just to understand what we mean by patient safety, about 10 goals are listed, and this is something which makes it easy for our whole team to understand. When we talk about patient safety, what is it we want to focus on? The first goal is to ensure the correct patient and correct eye and procedure. Second goal focuses on having the correct implant power and the correct implant design. The third is to prevent mortality or morbidity, because we are dealing with the older population who are more vulnerable. The fourth would include preventing hospital-acquired infections, including endophthalmitis, including hospital-acquired conjunctivitis. The fifth goal is to eliminate sight-threatening complications. So complications where the patient's final outcome may be very low, could be a glow perforation, could be a expulsive hemorrhage, or a RD following cataract surgery. Eliminate medical diagnostic errors. This becomes very important in the outpatient setting, where we ensure that we are diagnosing the patient correctly and treating appropriately. Ensuring correct medication is critical, as we know, and ensuring correct dispensing of spectacles as well. And ensuring physical safety, again, because patients who come to an eye hospital have poor vision and are the older generation. And to ensure appropriate treatment and follow-up, especially of patients who have low vision or who need immediate care. So while we have these 10 goals, I'll be focusing more on the first, second, and third goal through the course of this talk. So I'll start with 3 case histories. The first was when a patient came into the operating room, and when the patient was being prepared, and the patient was called for surgery, the patient, both the patients had the same name. So when the case records were placed separately, so when the patient was called, the similar named patient but a different patient came, and this was actually identified right before the block because of the correct checking of the case sheet and the medical registration number. But this is not uncommon, especially like I mentioned with our volumes we have in cataract surgery and in eye hospitals. You can have multiple patients with the same name. So using only name, and this is not something which can change overnight. So this is very important to have this as part of the culture, that every member of the team uses a second identifier. Most importantly, the medical registration number, to ensure we are always treating the correct patient at every step of the process. The second is we actually identified this error in the post-op examination, right after the surgery was done. This patient was brought in from the campsite, and this patient had equal vision of 5/60 in both eyes, and right eye was advised. When the patient came to the base hospital, the advice of surgery was changed to the left eye, because the right eye had a macular scar in the base hospital once the fundus was seen, and advice was changed. However, the wristband was not changed. So in our system, we typically have the patient's wristband tied to the wrist, which corresponds to the eye of surgery. So it was the right eye initially. So the right eye was the wristband remained in the right wrist, whereas the advice was only in the EMR on the left side, and this was not noticed. So based on this, the right eye was marked, and the right eye was blocked, and surgery also happened. And this was seen in the post-op period when the vision did not improve much. The good news is both the eyes, the IOL power was the same. So basically we did not harm the patient much, but otherwise we would have gone wrong if we had not picked this up earlier. So it is again, like I mentioned earlier, it is important to verify at every stage. And if we are changing for any reason, the eye or anything like that, in every aspect of caregiving, not just in your case records, be it your case sheets or your EMR or wristband or marking, at every stage, this has to be corrected, which is what is our protocol following this incident. In the third incident, the patient was advised surgery in the left eye, and everything was done correctly. The wristband was on the left wrist. It was marked appropriately. The eye was marked well. Case sheet, everything was done well. All the workup was done. However, the eye which was blocked was the right eye. This is something which we called as acute failure. And this was actually identified just before the surgery was, and this can again happen because sometimes with the right and left eye confusion, like we also see in our clinics, where we see a patient where we want to say right eye, but we advise left eye by mistake, and the counselor may identify and bring it to us. Again, it's very rare, but this can happen because it's a human element. So this is something called as an acute failure, where everything is fine, but once the doctor tries to give the block, they may have this rare incident happen. So to avoid this, we now ensure that we have a second person with the doctor, along with the doctor who's giving the block, to also ensure like we do a timeout before the block. So they also are there, and we also have the instrument set for the subtenon's anesthesia on the side where the eye has to be blocked. So having these 2 points introduced in the system has kind of reduced this significantly. We don't have that kind of risk now. So what has been said is that if you kind of follow the universal protocol, the chance of such errors of wrong patient or wrong procedure or wrong site can be reduced by at least 70 to 80%. And what is the universal protocol? This basically has 3 steps. That is to have a pre-procedure verification to confirm the correct patient, procedure and site, to have the correct site marked always in front of the attender. And this becomes even more important for a child who's going to go under GA, but even for the adult normal patients as well, because many of them may have hard of hearing and they may not be aware which is the correct eye. And to do a timeout mandatorily right before starting the procedure, or be it a block, or be it whatever procedure one is planning to do. So besides the issues with the universal protocol, we may also have upstream errors, like when the wrong eye is advised. That could also cause a wrong site procedure, or a downstream error where everything has been done well, checklist is administered, but right before the IOL is opened, the 2 IOLs are interchanged, and we have the wrong IOL, either power or design, implanted. So, but most important aspect which has been mentioned is to have to follow the universal protocol. So at Aravind, because of the high volume and multiple centers, it became very important for us to ensure we have a very systematic understanding and system in place to prevent this. What started off as trying to create awareness amongst our team also helped us compile these 10 patient safety goals. The culture of reporting, which is the most important and most difficult, because as we all know, behavioral change is very, very difficult. And to create systems, because creating systems can remove a lot of the human errors. Not to say that the individual who is giving the care should not be aware, but that is in addition to the strong systems we have. Use technology wherever possible, like we're using EMR now, so wherever we can have repeat reminders, confirmations, all of that, that will kind of remove the chance of errors. And if there is a deviation in care, to do a detailed root cause analysis to have a good corrective action and preventive action done, and redesign the system. So based on what preventive action is to be done, then you will kind of modify that. Like I mentioned, if you're having acute failure, we now have a second staff, a sister standing along with the doctor to ensure the correct eye is being blocked. So you might want to re-engineer some of the protocols which you have. And constant monitoring, which is, as we know, the most important way to control errors, and reinforcement that we're doing the right thing. So this entire process is important. So I'll just be sharing a video of the flow at Aravind as to what we do for our patients. I'd like the audio, please.
Each patient receives an ID card with a unique number specific only to them. This number is required to access the case file, significantly reducing the risk of opening another patient's file by mistake. When advising surgery, a pop-up confirms the eye to be operated on, ensuring the doctor verifies the correct eye twice. Human error in transcription can lead to misinterpretation, thereby causing wrong IOL power or incorrect IOL type being implanted. Hence, we developed a system which is fully automated, wherein the patient's biometry is directly uploaded to their case file in the Electronic Medical Record or EMR. After the patient confirms their lens choice and signs the consent form, they receive an appointment slip to present on the day of the surgery. The list of the next day's patients, including their IOL models and powers, is downloaded from the software by the store staff, who ensures that the inventory has all the necessary IOLs set aside for the next day's surgeries. On the day of the surgery, the patient's case sheet details are verified against their appointment slip and unique ID. Verification is crucial at every step. The eye to be operated on is confirmed with both the patient and their attendant. The ID card is then attached and dilating drops are instilled in the eye to be operated on. After payment, a wristband with the patient and eye details is printed and placed on the wrist corresponding to the surgical site. The details are again verified and a sticker is placed on the site of surgery in the presence of the attendant. The patient is then moved to the daycare room where the perioperative record list and surgical checklist are attached to the case sheet. In the block room, the patient is prepared for the operating room. For surgery under topical anesthesia, the pre-anesthesia checklist is administered here and topical drops are applied. For subtenons anesthesia, the details are verified by both the OR staff and the doctor. The IOL power on the case sheet is confirmed with the A-scan and the pre-anesthesia checklist is administered. The instrument set is kept on the side of the eye to be blocked. The patient is blocked in the presence of an OR staff member to avoid any acute events of wrong side block. The lens is obtained from the store after entering the patient's details and scanning the barcode on the IOL box. Avoid incorrect lens dispensing. After verification, the patient is then moved to the OR. Here, the details are checked against the wristband and a before incision checklist is administered by both the doctor and the assisting staff before the surgery begins. Before opening the IOL, the patient's wristband and case sheet are again verified by the assisting nurse. After the IOL is implanted, the surgery is completed. The post-op checklist is administered just before the patient is shifted out of the OR, ensuring that the surgery is performed on the correct patient, the correct eye, and with the correct IOL.
So that is just to give an idea of the flow. The other aspect, the third goal which I mentioned about, is to prevent significant morbidity or mortality in an eye hospital. For this, we try to ensure we have all the documents collected regarding the systemic condition and the medication. All this is entered, and the pre-op workup is done and get the physician's fitness. And for patients who have the details like like no systemic history or controlled blood sugar and hypertensive patients, they need not be seen by a physician, but they're all monitored. They all have an ECG. For other patients, they are seen by a physician, and most of our tertiary centers have a physician in-house. And secondary centers where we don't have a physician, we request them to get a physician fitness with the format which we give for all the patients. We also have these kind of charts put up, so the patients are aware and our team is also aware. It becomes very clear for communication. And again, during surgery as well, these patients are prioritized. We have another OR staff who's with them to ensure that they are being monitored during surgery and their wait times are not long. So all of this will ensure we reduce the chance of systemic morbidity, and we also kind of very closely assess what is the number of patients who had an emergency. So this is just to list the number of emergencies we had for the year 2024 across all our hospitals. So it is about 4 per 10,000. Some of this were not very significant, but we still would like to ensure in any code blue, anything which happens right in the OT or before or after. By ward, we mean either before or after, right after the block. We even have 2 or 3 under topical, and then they have some anaphylaxis to topical anesthesia. So all of this are also collated and monitored, so we know that we are actually taking care of them, and they are made sure that we revive these patients even if they've had a significant emergency. The incident reporting system is very crucial. So right now we have an online portal, but we also started off with just a paper and pen. So we would just ensure that anyone who finds a deviation from the routine, It could include things like a sentinel event or anything with wrong documentation, wrong marking, which did not result in a sentinel event, but a near miss. All of this also are entered, and this is where what make sure that any staff, and this is all anonymous. So this way, we would encourage our team to report whatever was not the norm for them. So once sentinel event does happen, it becomes very important to ensure we go down to the depth and understand why it happened. The corrective action and the preventive action is also analyzed in detail. And it's very important to remember that a lot of time we are at denial and say this is a very, very, very rare event. This will not happen. It's like 1 in 10,000 or 2 in 10,000. So should we give this kind of care? But like endophthalmitis, we take so much of effort to prevent one endophthalmitis. So putting the strong systems and ensuring that irrespective of what we follow it is important to prevent these errors. And the training is very important, especially when you have new staff entering. And regular meetings within smaller teams and larger teams are also important while strengthening the incident reporting system. So to conclude, it's important to remember when it comes to sentinel events, our goal is to be 100% right. 99.9% is not good enough, and a comprehensive time out and deployment of checklists and working with the staff to influence their behavior positively are all critical to ensure this happens. Thank you.
Thanks, Dr. Haripriya, for extensively covering that. So we'll take the questions in the end. So I request Dr. Shivakumar to talk about ensuring good visual outcomes. Or you want to take any questions for Dr. Haripriya, because she has to go for some other session. Anything you want to clarify? Okay, thank you. Thank you.
So I'm grateful to the organizers and to AIOS sir for this opportunity. I'll be talking about ensuring good visual outcomes. I have no financial disclosures to make. So we all know that cataract surgery with IOL implantation is the most commonly performed surgery and also the most successful. And not only we, but all the patients also know it. And so the patient's expectations, especially for spectacle independence and good functional vision, is very high these days. So while we still believe that a good quality surgery, a meticulous surgery, results in good quality outcomes, we'll now see that there are many factors which influence it. So as we saw with the previous talk, the quality journey starts with the first step. The first step in the quality journey is safety. So here it involves safety in biometry and safety during surgery, which are the key factors for a good visual outcome. And this is necessary at every step and every interaction with the patient. And the surgeon and the entire team has to ensure at all times, with a timeout being so sacrosanct, that he is dealing with the 4 C's: the correct patient, the correct eye, the correct procedure, the correct implant before starting the surgery and just before implantation. An excellent outcome in a wrong patient or a wrong eye has absolutely no meaning, because the patient is going to be dissatisfied. Now, the entire thing starts with a preoperative evaluation, where a thorough and structured preoperative evaluation is very essential for prognosticating the visual outcome, knowing whether the vision loss is only due to the cataract or if there's any other comorbid condition. And with this, we can clearly explain the visual prognosis to the patient so that the patient is not dissatisfied, and we take an informed consent for this. It also helps in recognizing the risk factors that could lead to the need of adjuvants like iris hooks, CTS, etc., or for additional procedures like vitrectomy. And these cataracts can also be classified based on these risks. So group 1 has no risks. They are good cases where complications are not expected. Group 2 are prone to complications like a shallow AC, brunescent, mature, hypermature cataracts, and with short axial length and long axial length. And group 3, where complications are a definite certainty, like a PC dehiscence with PPC or with a post-VR cataract, and also subluxated or traumatic cataracts, where vitrectomy is definitely essential. It also helps in proper allotment of patients according to expertise in a multi-surgeon setup, where surgeons with expertise will get cases like small pupils, brunescent, or mature cataracts. And for the surgeon also, it helps in selecting the proper procedure, like whether to go for MSICS or phaco, depending on his limitations. for a case with old age, prunescent, and endothelial dystrophy. Also, it helps in ruling out any infective focus predisposing to endophthalmitis. Now, the important thing about getting good visual outcomes is, of course, accurate biometry. The biometry is wrong, even with a good surgery, you'll never be able to achieve good visual outcomes. So a proper selection of biometry modality, depending on the cataract density, whether we go for optical or immersion ultrasound, it is very important. Also, to calibrate the equipment every day at recommended frequency, like the optical biometry and ultrasound every day, and other instruments like the Varion on their regular basis. To have a trained staff, preferably a team, for consistent outcomes, so that they are also developing their expertise and we can have reliable outcomes. Ensuring proper measurements, selecting the appropriate modes wherever applicable, like in post-LASIK cases for post-refractive surgeries and in silicone oil-filled globes. The biometrists or ophthalmologists, if they are measuring it, should always apply the holiday criteria for verification of biometry. The biometry should be done for both eyes, and if there's an excellent difference of more than 0.3 millimeters, which translates to 1 diopter roughly, less than 20 mm, which is a short eye, or more than 26 mm, which is a myopic eye, or if the average K difference is more than 1 diopter between two eyes, which again translates to a difference of 1 diopter, or if it is flat, less than 40 diopters, or steep, more than 48 diopters, or if the astigmatism in any eye is more than 3 diopters, then it should be repeated. And again, if the difference in IOL power is more than 1 diopter between the two eyes, the biometry should be repeated with a different modality and preferably with another biometrist. Again, selecting the appropriate residual anticipated refraction is also very important. We would like to have a slight minimal myopia of minus 0.1 or minus 0.2 in the normal monofocal cases or even for some EDOFs. But for multifocals, it is better to have the residual closest to 0. Also, to undercorrect the with-the-rule astigmatism in patients with toric IOLs when by 0.25 cylinder. Also, to select the appropriate formula and constants. So, optical constants if the entire biometry has been done on the optical biometer. Personalized A constants if it is possible to refine our results. Also, the latest formula like the Barrett suite, like universal 2 for almost all axial lens, the true K for post-LASIK cases, and toric true K for toric IOLs. Nowadays, KN is, for example, KN is recommended for extreme axial lens. And finally, we have artificial intelligence coming in with the Hill RBF. There are challenging cases like post-refractive surgery or cases with posterior staphyloma where you can get a lot of varying readings. So in these cases, it is always good to have a consultation for expert opinion from a biometrist to an ophthalmologist, or if it is by an ophthalmologist with his peers. Also, using the appropriate updated online calculators for special cases, toric IOLs is very important. And whenever we are transcribing from one machine to another or from toric sheets or into toric sheets online, there should be a clear transcription and clear documentation, and we should always be constantly monitoring and refining. The surgery advice should also be appropriate for on the decision. The appropriate decision should be done on which eye is to be operated. The selection and advice of appropriate IOL types depending on the patient's needs and expectations, and to explain the appropriate visual prognosis to the patient. Ensuring quality surgery starts with ensuring proper sterilization disinfection protocols. So there should be a monitoring and documentation of all the chemical and biological indicators having changed. Regular calibration of the sterilization equipment which we are using, be it autoclave or ETO, and a regular calibration of HEPA filter and other environmental factors. Again, ensure use of standard good quality consumables, always from reliable vendors, not changing the brand often, but staying true to a brand which has given good results. Check the quality, especially for clarity, against a white background and a black background for solutions like the balanced salt solution or the viscoelastics, and preferably have the culture reports for every batch. Ensure that equipment are in good order and have a backup like phaco machines and microscopes. Case allotment as per skills, as we have seen previously. Have a proper surgical plan for complex cases and handling of complications. And of course, this is the backbone, a meticulous surgery with proper wound architecture, a well-sized centered capsulorhexis, 5 to 5.5 mm in a phaco, 6 to 7 mm in a rhexis, appropriate phaco parameters so that there is no fluctuations in anterior chamber, complete cortical removal, and IOL placement in the bag with 360 degrees of overlap of the capsule rhexis. It is very good to have a trained assisting team who understand without much of verbal interaction with the patient on table, ensure low rate of complications so that you know that your outcomes are going to be good. In the post-operative protocol, we should ensure a low incidence of post-operative complications, and there should be a standard post-operative protocol, preferably separating the steroids and the antibiotics. Steroids for a 4 to 6 week period and antibiotics not more than 15 days. Effective management of post-operative complications, which would include a standardized protocol for both timing as well as indications for resurgeries. Accurate recording of day one vision is very, very important. Especially check the uncorrected visual acuity and the pinhole. For this, ensure that the distance is correct and ensure that the illumination of the charts is also correct. And if we find a large difference between the uncorrected vision and the pinhole and everything is clear, then we should suspect the biometry and we should repeat the biometry so that we can address this issue at the earliest. In follow-up, be it at 3 weeks, 4 weeks, 1 month, or later, there should be an accurate visual acuity record with the uncorrected visual acuity being recorded, and it is an indicator of the post-operative astigmatism and also how the patient feels without glasses. So with this, we can also calculate the surgical induced astigmatism. We can improve the UCVA by addressing it, and also we can shift to temporal SICS whenever we are doing SICS. An accurate refraction should be done, and spectacle prescription should be given as per the patient's needs, especially at what his working distance is, especially for the near vision, and ensure proper post-operative care so as to ensure low endophthalmitis rates. And this also includes the general instructions that we need to give. So with all this, we come to monitoring the outcomes and refinement. So when we are monitoring the outcomes, the first thing that we monitor is from the refraction, we can get the post-operative spherical equivalent. And this is indicative of our biometry accuracy. And with this, when this is being monitored, a further refinement is possible. The other key performance indicators to further improve quality would be the intraoperative complication rates, post-operative complication rates, endophthalmitis rates, and also the percentage of patients who have obtained an uncorrected and best corrected visual acuity of better than 612. And more importantly, whatever be the volume, it is important to maintain a database so that you can always go back and do an audit or scrutiny. So depending on the volume, manpower, and technological access, we can have simple Excel sheets through which we can filter data, or MS Access, or we can also develop a software for capture and analysis. And with this, the outcome details can be compiled in the database for regular audit and scrutiny. This helps in refining processes like biometry, like if any change in the A constant is needed for a particular IOL, or helps in modifications in surgery like shifting to temporal SICS for better uncorrected visual acuity and astigmatism management. It also helps in increasing the uptake of toric IOLs in patients undergoing phaco with pre-existing corneal astigmatism. So with all this, we can improve our visual outcomes. So to sum up, good visual outcomes depend on various factors, not only on skilled surgery or premium IOLs. It is all teamwork, and incremental improvement in quality can happen only if outcomes are captured and analyzed for further improvement in the processes. Thank you very much.
Yeah, thanks, Dr. Ashok Kumar, for elaborating all the points. We'll have a discussion at the end. So now I request Dr. Venkatesh, he is the Chief Medical Officer of Aravind Pondicherry, to talk about understanding patient expectation and monitoring patient, how do you monitor the satisfaction as well?
Thank you, sir. Thank you for the opportunity. I'll just show you the next important part of it. Now, we saw in that pyramid how important is safety, and more important is how we are patient-centered care, because this is the foundation on which all your efficiency, effectiveness, and timeliness and equity is going to be there. So I'm going to share some of our experience on how we understand and how we monitor some of this, because you know what happens if people are not happy in your system. So what has stood the test of time for everyone, including Arvind, is, of course, what Shivakumar was beautifully talking about, the quality of surgical work, the ease and accessibility and affordability of the care, and also the compassionate care which we give to these patients. But why do patient expectations matter? It really matters because what do they expect from us? No, that also we need to really understand sometimes on a day-to-day basis. And in this changing world, now I'm sure in another few years you'll have a new generation of patients coming in. We should know what they expect from us. So they expect definitely a good quality of care, what the outcomes which they get. Very good communications from us, whoever is doing. When we are talking about this team, everybody should be communicating. Even your security should be communicating the right thing. And of course, personalized attentions. When it comes to elderly patients who are vulnerable, who need access to a lot of support, you need a personalized attention. So what happens when we meet those expectations? We have seen this. But this is quite rare. When they are really very happy, they go in and write somewhere, right? But if you don't meet, you won't have those satisfied patients who are reviewing for you. What happens if we don't? That's when we see all these reports. Even yesterday night, I was not happy in the place where I'm staying. The minute I wrote, that guy came to my room and he said, I'll change your room. It happens, but sometimes, we'll have to keep listening to our patients also. So how do we know if they are satisfied? So what we are doing at this point of time is, we have a lot of feedback kiosks like this, like how you see in airports, in many places within the hospital. And then we have a dedicated call center, which is called a PACI, where PACI means it's like you talk to the dedicated call center person. Whatever be, you want to change dates or you want to know when you can take your head bath, things like that to clarify. Because once it goes to an operator, then they are not connected, they are unhappy. And then, of course, through reviews. And this is one thing which has helped us, at least in the last couple of years, I would say. Once you register, you get a WhatsApp number. And when you are there, it is very easy to kind of satisfy them. So they can send a WhatsApp message of if they are waiting longer or somebody is talking rude, so that you can attend to it, than doing a postmortem later after seeing a review. And of course, some of these suggestions are very interesting. Like this is one thing which I got recently. It says, name board in the Kadalur to Pondi Road is not visible. Some trees are hiding the boards. Things like this, which you never even imagine, because the hospital, the entrance gate. But for him, it's saying it's hiding. And then when I went and checked, we had to chop off some of those branches to make it better. So some of these interesting things you get. And this is one thing which we do routinely for our cataract post-ops. Even whatever you have all these, these forms really make a difference. You can go virtually online, you can get even in your iPad and things like that, whether you're satisfied with your intermediate vision, your near vision, when you're doing a multifocal or an EDOF lens. And that really helps them to talk to them if they are not happy. And for every inpatient, surveying something like this, getting about how their outpatient care was, how their inpatient care was, how the other allied services, including your canteen, coffee shop, securities, insurance, everything matters. So I'll just share with you some of the insights we got from this feedback and how we have been trying to kind of work on it. One thing which we always get is long waiting times. I see some smiles here who are alumni of Aravind. They have pretty big smiles. When they say you come into Aravind or any facility, it takes 4 to 5 hours, long waiting times, more clarity in communication. I don't remember the post-surgery instructions, which the paramedic gave. And after I went home, I'm calling somebody or asking somebody. How do you improve on all these things? So especially COVID was a big learning. I'm sure many of you didn't want to let that good crisis go waste. We did a lot of experiments in Aravind, including something called scheduling, which we never did before because we were a non-appointment system. Everybody was walking in at 9:30, 10 and crowding the OP, and they were bottleneck at different points. So once we started scheduling, they got an entry time. It's an entry for registration, not to see a doctor. They were happily having their breakfast, having a coffee break, and then coming to the registration. And this really helped us. This is something like getting your passport scheduled time. Once you go in, you'll be done in another 1 hour. So the examination also happens in a couple of hours. Then we introduced something like a token system within the clinics to identify. Again, it brought a safety. Instead of calling them by name, we had a number display, and then they would just get up and then we would go and attend to them. It made the job much more simpler. And counseling, this we realized during COVID that there was a big bottleneck in counseling, and then we realized 50% were other eye. Can we segregate them? Can we do them within the units than sending them to the counseling room? Because it's the same lens and the same procedure. And just by segregating, we were able to save a lot of time for that. So even if you do study and small analysis and then you do small improvements, you can definitely work on some of those long waiting times which our patients have. Especially this clarity in communication. It keeps on coming. Now, is the hospital and insurance company? No. We are just helping them to get the insurance. But they don't see you like that. They come and say, you didn't give me the money which I am supposed to get. So we just changed the name. This idea I got from one of my colleagues who practices in Karur. He said, it's an help desk. I'm not the insurance office. I'm just helping you. Just that name can change the mindset of your patients. I can tell you, just go and try this. If you say insurance office, say insurance help desk. You are helping them to get that insurance. And things like this will take a certain time, and then QR codes for taking the instructions of HFA and being prepared for the HFA or a OCT or whatever test you do. If you have very good videos, QR code really works. Something like this. Even if the patient doesn't know how to save, a paramedic help them to save. This is post-operative instruction, which is a 4-minute video. They scan, they save it, because the minute I go home, somebody else is the caregiver. If they go and show those videos, your calls in the post-operative period significantly reduces. So things like this can make a big difference. So wherever possible, now you know how people use these codes comfortably. Post-surgery instructions, hard to remember. A lot of calls keep coming to the call centers before, but now it has significantly reduced. This is a simple timetable we have introduced. This was an idea from one of the ashram patients who used to come. So can you give me a timetable? You are 8 times for 5 days, you are 6 times for 5 days. I'm not able to track. Can you give me something which I can tick? So she gave me a model. And I said, what a brilliant model. And we did with something like this. And it's really helping many of our patients. So even a simple timetable like this, it may look very subtle, but it may make a big difference. You won't get post-operative iritis, I'll tell you, because they are going to put their steroids properly. And all these little things matter. Can you get the audio? Boss. So if you see, this is one of the patient's idea, in fact. I'll just show you again what happens. See, she's ringing the bell. So every wheelchair has got a bell now. So that just is a simple idea from one of my patients. In fact, he sent the bell. So I was forced to put it into the wheelchair, and then we saw the difference, right? So whenever there is no way, you can just ring. It's like the airport buggy where you make a small noise to give the way. And this is another brilliant suggestion given by a patient. He said, Aadhar, they have a dual screen. Can you put a dual screen so that there are no errors in my name or the address you collect or the contact number? What a brilliant idea. And then you can see the QR code on the dual screen so that they can easily scan and pay their amount. Otherwise, sometimes you have to collect the phone and do all these things. So to know patients what they need better, what we did was we significantly worked on this, looking at their needs in the near, intermediate, and distance. This really helps you to decide the lens. Many of the time, I think you would have seen in your practice, people come back and say, I didn't know what my lens was, right? Otherwise, I would have gone for the EDOF. I would have gone for multifocal. Can I know the needs of the patient? And I'll just show you a quick audio.
Cataract surgery has evolved, offering a variety of intraocular lenses to suit different visual needs. But with so many choices, how do our patients decide? At our facility, we simplify this process with a comprehensive needs assessment. Patients' daily activities, profession, and vision priorities are carefully evaluated, assigning scores for near, intermediate, and distance vision. Based on these scores, along with a thorough clinical evaluation and biometry, we recommend the most suitable IOL while clearly explaining its benefits and trade-offs. To enhance understanding, we introduced virtual reality counseling using an app developed by our team. With a smartphone and a VR headset, patients can see the world through different IOLs, experiencing firsthand how each lens enhances vision at various distances. Even if a patient's vision is limited, caregivers can step in, ensuring an informed decision. This technology also enables efficient counseling in our high-volume system, ensuring that every patient receives clear and informed guidance. Following this intervention, we had a significant increase in uptake of premium lenses in the last couple of years. Through this innovative approach, we empower patients to choose an IOL that truly fits, bringing clarity, confidence, and the best possible vision.
So you have to remember the caregivers are the next generation. No, they are ready to use all those technology. You can think how the patient can feel, but they can feel what their parents can see after surgery, especially if you're going for EDOF or multifocal or even a toric lens and how astigmatism is. So all these things, I think once you start seeing as a practice, you can see a big change the way you deliver some of your surgical practices also. Before I complete, I'll just show what is happening here. So this is actually my caregivers of cataract patients. No? Every day there are at least 15, 60 or 70 caregivers of your 70 to 100 day cats. So what do you do them? No, they are watching all around. They are waiting to write your reviews if they are not going to be happy. So how do you engage them? No, we had a beautiful campus to engage them. So what we are doing is we are doing something called a green tour, no? Where they're taking them on the facility tour, showing them some of our green practices, showing them how we are eco-friendly, no? The glass bottles which we have here. So he is one of our fire officer who is trained to do this, and he knows in and out of all the trees and plants there. I don't know, he's like an encyclopedia. So he takes these patients, caregivers, who are mostly young people, on a tour like this. He tells them how much of solar energy we generate, how much water we recycle, how much water we harvest from the rain. Because all this, he's got data in his hand, and then he goes around, shows them with some information. So we have some information boards there. This is about the solar. We generate 540 kilowatts, which is almost 65% of the needs in Pondicherry facility. And then he shows the DWatts plant, which recycles water. Almost 90% of water is recycled. And after the surgery, I see more feedback on him than the surgeon or the surgery. Okay? So many people write, no, we had something useful I learned today. No, how much of solar we can generate at home. And he also kind of introduces them to the people who do us for us through the Auroville team. But few things like that you can see, and this definitely shows how the data, this is a year data looking at outpatient, other services and inpatient. If you see, there is a subtle difference, but the orange is becoming more blue. That is the most satisfying part. There's becoming more excellent now. And if you see the average and the poor is significantly reducing, and mostly those are in the canteen, coffee shop, where I'm not able to really take care of all the taste buds. But definitely we have all these future plans. I'm not going to bore you with this. I'm sure you'll all be exploring all these AI chatbots and things like that. But I think the patient-centered care and listening to patients and making sure you bring some of those practices and showing them you are really listening is very important in taking your care to the next level. Thank you.
Thanks, Venkatesh. Venkatesh is quite passionate about tracking, making sure the patients are happy, and he really wants to get the feedback from them. I'll just talk about our monitoring tool. Can I have another presentation? Yeah. Yes, this one, yeah. So Dr. Sivakumar spoke about, how do you get good outcomes. So I'm just showing you a structured tool which we have. This is about, we are talking about the effectiveness part. When this the pyramid we saw earlier. So whatever we are talking is about effectiveness, which is about how do we minimize complication, how do we maximize the visual outcome. So some of the values which drive the effectiveness is the quality of your resources, the microscope, the phaco machine, the surgical instruments, the sterilization, all of that. then how do you adopt evidence-based practices? And equally important is the training of your HR, which means the doctors, nurses, and equally the most important is monitoring the outcome. So if you don't monitor, then you cannot learn from that. So we have created a software tool called Cataract Surgery Outcome Monitoring Tool. So here, earlier we used to enter all the data manually. Now it's all entered through from the EMR, and we have a way of data verification, data confirmation, and then once it goes into an Excel sheet, from that it comes into this particular thing. And what are the things we monitor? We monitor everything like pre-operative, the surgical, the post-operative, the follow-up, and also the endophthalmitis. The most important, I've colored it like intraoperative complication rate, the resurgeries, the follow-up uncorrected visual acuity, follow-up best corrected visual acuity, the spherical equivalent to make sure that the biometry is done well. So, and this is basically how it looks like. Like when you look at the pre-operative data, we are looking at how many patients have come with advanced cataract in the surgery eye. It's like 2.4%. And then what is the number of patients with vision less than 6/60? What is the percentage? So all of that, like I was telling earlier, and this is a long list. So like intraoperative complications and post-operative complication. So, and resurgeries. And the immediate post-operatively, the period, what is the visual acuity the patients have, the follow-up advice. So it's a long list, follow-up examination, how many patients actually came for follow-up, what is the vision at that point, uncorrected, miscorrected, was there any complication during that point, and what is the spherical equivalent, looking at the thing. So this is basically the tool as I wanted to show it. So anyway, what do you do with this information? You have a lot of information. So we have weekly review meetings. What do we review actually in this meeting? We look at the patients who had surgical complications, patients who had a post-operative surgical complication, patients who had resurgery. So when there's a complication, why did that complication happen? Is there anything we could have done to avoid that complication? Okay, the complication has happened. Was it managed well? And what is the outcome of that complication? Did the patient again need a resurgery, or the patient went back home well? And what was the visual acuity they got? Was there any patient who came back with an infection during that period? Was there the patients who had the 2 months back they were operated, and those patients, what is the visual acuity level? So all of that will use this information. And about matching the complexity and with the competence Dr. Shivakumar mentioned. So we based, as a routine, as you can see here, this is our EMR. We divide them into group 1, group 2, group 3 based on this. So all the hard cataract, mature cataract, like high myopia, high hypermetropia, post-trabeculectomy, all of that becomes a group 2 or a complex surgery, we call it. So, and the group 3 is the one which have like subluxated cataract, post-VR cataract, post-injection cataract, and faculatic. I mean, like the group 1 anybody can do, group 2 it has to be done by an experienced surgeon, group 3 it has to be done by the senior most surgeon. And we also mandate that the group 3 the doctor should see before they operate. Otherwise, rest of the cases, the nurses decide whom will operate that. We also make sure that this also helps in getting the guarded visual prognosis from the patient. We are also able to prepare them pre-operatively so that we can minimize the complications. So all of this really helps. And again, we also focus on the surgical training. We in our system, we make the trainees or postgraduates or the fellows competent within 12 months to operate independently. So that is how now we are able to also maintain quality. But in the 12 months, they really do adequate number, at least 40 to 50 surgeries to make them independent. And we also have set a goal of every postgraduate doing at least 300 surgeries, because we had seen only when they cross 300 surgeries, the complication rate also drops below 2%. So we have those numbers and we also implement that. And for the first 150 cases, we have Oscar scoring as well. And again, one point of time, initially the first year, second year, any complication happens for a trainee, it has to be managed by a senior surgeon. But when they come to the third year, They are also given a CME on how they can manage by themselves. And they also get an opportunity to be a trainer for the next batch of doctors. So when they become a trainer and train the next batch, they also become even more competent. So they really understand what it means to teach. So all of this helps to make the doctors better. And again, we track the follow-up uncorrected visual acuity, as he said. So we look at, the first line is uncorrected vision of here. I'm not able to. So uncorrected vision of 6/6. The second bar is the patients who had a 6/9 and 6/6. The third bar is 6/12, 6/9, 6/6. And 6/18 means, all those who had 6/18 and better. So these are all uncorrected vision. And we have set a goal of, at least 6/18 or better should be 95% in phaco and 85% in manual small incision surgery. So, and again, for this to work, we also should have an accurate biometry. So here again, we track the spherical equivalent. We would like to see that, if it is optical biometry is used, the 0.5 diopter error should be more than 90%. If it is a ultrasonic biometer, contact means it should be more than 85%. So we also have certain benchmarks. And not only that, for each individual refractionist or biometrists who do the biometry, we also generate a list to see if there is any particular error in that particular person as well. So we have been tracking all these outcomes for the last, since 2011, 2012. And we had published in the year 2021 of the outcomes of about 6 years of about 1.86 million patients in the eye journal. So I'm just sharing that. During this period, we have done about 577,000 cases or 5.7 lakh phacoemulsification procedures. And we were able to show that there is a reduction in the complication rate from 1.3% to 0.7%, while the re-surgery level remained the same. And again, when we had done about 1.24 million manual small incision, here the complication rate has dropped from 1.8% to 1.3%. And again, the re-operation rate did not change. Then we also look at the uncorrected visual acuity. The uncorrected visual acuity in manual small incision surgery of vision, of uncorrected vision of 6/18 or better, improved from 66% to 85%. A lot of that is because the way they change the incision, but also the way the refractionists do the refraction. When we know that we are giving importance for the uncorrected vision, they also document it in the proper way. So otherwise they may not also do a good job about that. We also noticed from the data that the patient who had a poor visual outcome of less than 6/60 at 1 month follow-up again dropped from 2.5% to 1.7%. So I'm sharing all this data. So this may be a big data, but your own practice, if you have, like Dr. Sivakumar said, you can even document all of that and even in an Excel sheet. Now, if you do it, then there are now AI tools are available. You'll be able to get a good report out of that. So, and again, last year we also looked at and published it in the year 2025. Now, we looked at almost like 12-year data of similar thing. When we looked at the post-operative mean visual acuity, what is the vision that has happened. I'm going to show you 4 graphs. The first graph, you see in the bottom, the vision on the top is poor, the vision in the bottom is better. Okay, this is 624, 618 and all that here, and we have 66 here. And this is a phaco. If you look at the best corrected visual acuity from 2012 to 23, it has not changed much. The best corrected visual acuity remains the same. And if you look at the uncorrected vision in phaco, there has been a marginal improvement. It used to be between 6/12 and 6/9. Has become better. It is now between 6/9 and 6/7.5. So there has been an increase. So this kind of subtle improvement you can see only on a long-term basis. The small incision best corrected visual acuity again has improved. Reasonably from 6/9, it has come between 6/7 to 6/6. And what is interesting is the uncorrected visual acuity. So which used to be like 624, has become now, it is has come close to 6/15. So, I mean, all this data is important. If you collect the data, you can look at it. So, another interesting thing about this tool is we can also know the patients whose vision has not improved. For example, these are the patients who we have taken for surgery when their preoperative vision is 6/12, and post-operatively what has happened to this patient. How many of these, whoever is on red, the vision is poor. So these are all data which were recorded between 8 days to 45 days. Some of these would have become better after some point of time. But you can have a record of that. For here, the vision has improved in almost 96% of the cases, not changed in 3%. It has deteriorated 1.38%. But we have a tool to extract the particular patients where the vision has become deteriorated, and we can also look at, see and analyze what has happened to these patients. So just to conclude, now when these data, what I'm showing is the doctors can see. The individual doctor will be able to log in and see what is the data, how he has done from, if he has done a 3-year fellowship or a 3-year residency, he'll be able to see all the data from the beginning. And that he also will be able to benchmark himself with another doctor, another postgraduate. He can compare himself, if he has done about 500 surgeries, he can compare himself with somebody who had done a 500 surgery or 5,000 surgeries, just to compare himself, where he stands. The data gives what is the average data and what is the best data as well. And we also were able to show that the incision architecture matters in manual SICS. And this also helps to minimize the complication, understand the cause for the poor vision. And we also were able to change the A constant of at least one IOL, where we found that this IOL, with that A constant, we were consistently getting hypermetropic refractive error, and we were able to find that and change it. These are all not possible if you don't do that. So, the overall, whatever way, what the whole purpose of this is to share some of our best practices, and also to share with you that the concept that you have to track in some way or the other, so that you can make a change in your practice, so that the patients can become better. Just going back to the first slide. So any organization, any practitioner would like to see the volume of these patients coming to them increases year by year. And if you are able to make sure that the quality, the clinical quality, and the the service quality, as Dr. Venkatesh mentioned, not just the patient, but also the attendants. If you are able to address that, definitely you will see increase in the volume of patient coming to you year after year. Thank you. So we can take any questions, anything, comments, or anything you want to share from your own practice. Anything you want to add, Venkatesh, as like final remarks?
The safety is a mindset. Like Haripriya was beautifully saying, it's very, very difficult to get that sometimes into the team. So especially encouraging them to report the near misses, because that is more important. So once you get those near miss or the touch points where in the last minute they found something and corrected it, then we can really analyze why this has happened. So they say that for every incident or a sentinel event, there would have been thousands of near miss, like how we know in accidents, right? In that particular place, we would have escaped 1,000 times. And one fine day, we may have an accident. It's like a wet floor. Now there will be thousands of people walking, but one fine day, somebody would slip and fall. But can I prevent that wet floor? I mean, looking at that is so important. If somebody has slipped but not had an injury, they should be reporting it. Not when the injury really happens. Like for example, last week, there was a fire nozzle where a young kid, I don't know, the kid was playing, went under the nozzle, and then he had an injury here, which we had to suture. Can we look into that? There are several times near misses would have happened, or some would have gone, not had an injury, but how do you recognize all that? Is by reporting. So if you have a mechanism of reporting those incidents, we do online, anybody can do, but it's more important that it's anonymous, right? So we're not going to blame anybody. So the team have to understand that it is not to do a blame game, it is to find and solve for the future, or resolve for that it should never happen. So I think that's the more important part in that safety message, getting those early problems into picture so that you don't have a bigger problem coming up.
Anything, Sir Kumar?
And so when we are looking at good outcomes, we generally tend to look at only good surgery and other things. But what I wanted to highlight basically is that there's a lot of planning which goes into it. There's a lot of teamwork that goes into it. And it is not just the surgeon alone, but the team surrounding him, but also which should be very tuned to doing good quality work. So anybody who is defaulting on that, the quality of surgery can go down. So it's very important to build a team which is very, very passionate about quality, and they should know about all this. It's very essential to attune to them, saying that it's not only the surgeon's surgery which is going to be a deciding factor for good outcomes, but these are the various things, right from the preoperative examination to the biometry to the post-operative care. So when this is brought into the consciousness of the team, automatically the team will be oriented towards working. Otherwise, the team doesn't know that, it's doing good work. And that is why also analyzing the data, collecting the data and analyzing is important. It's not only we surgeons who know how well we are doing, but the biometrists know how well they are doing, and they are pushing pushing themselves forward for more accuracy. So it helps us in another way to make everyone aware about the reports, about the details. So quality is something which is, the outcomes at least, has to have some wholesome inputs for very good quality. So this is what I wanted to.
Thanks. Any other comments, Venkatesh?
Any questions?
Any questions?
Yes, Abdul.
For a small practice or a small trust hospital, of course, Arvind is a big system actually. What matters most, as you said, the teamwork. So the staff has to be provided psychological security. The staff has to be provided psychological security that if they bring out any issue, they won't be judged, and the doctor or whoever is in charge would look at that from a systematic issue or a systematic problem. And it won't be possible to, stop everything. Idiosyncratic problems like a child hitting one somewhere. But of course, we can put those problems into systematic buckets and, see if we can solve them. So providing staff with psychological security that the job is protected, even if they bring in some adverse events or something, that has to be there. Until we take care of that, they don't bring out the issues actually.
I think that's a brilliant point. I think if you bring that kind of a systems approach in some of these things which happen, let's say that there is a cable here. So the systems approach here is to put a sticker on top of it, right? This didn't happen several years back. So some people would drip, the cable would fall, or the mic would fall, or the person itself would fall. I've seen Malaravan falling in one of the APAOs in Bangkok. So things can happen, no? So how do you systematically solve this? So this is a systematic solution. Just now we were seeing in a coffee area, near that coffee area, I don't know where we have a mat, but the mat is lifted on one side. I'm sure many of you. So that at least 3-4 people I saw when I just had a tea there. So now we'll have to fix it. So I think it's like that. So your staff has to understand that you are just raising this alarm for us to systematically solve this, not to find blame on you or somebody else.
Okay, thanks, Venkatesh. I just want to close with one remark. So, go ahead.
I see a lot of inertia in using AMR. Even the staff, the nurses, the paramedical, and sometimes even the doctors. How to push it and how to go ahead at all levels. It's a very challenging.
It's challenging, So we also have EMR, we also have the same problem. Some of the things you have to mandate, having a rule engine to make sure that the data, if it is not entered, you cannot go to the next. So you cannot do it for everything, but there are certain areas where the doctors may not be interested to enter the data. Is there a paramedical person can do that job? You can see, like entering the compliance, systemic medication, systemic thing, all of that, you have to find a alternate way where the doctors may not be interested to enter the data. So whereas the paramedics will enter all the data, the doctors, but like an anti-segment finding, all that, they have to do it. But we also slowly have to move towards documentation, digital documentation, taking photograph of the anterior segment of the eye or posterior segment of the eye. Maybe there are some of the ways we may have to systematize so that we are able to generate data from that rather than from the doctor's thing. But I just want to conclude by saying that, the AA is coming in a big way in medicine, in healthcare, and also ophthalmology is no exception. And soon the gap of the clinical knowledge or the clinical skill or the surgical skill is going to become very, very narrow between providers. Today, that is what is differentiating somebody's practice. When the AI tools all come, that will go away. What will remain is what is the experience you're going to give to your patients when they come to your facility. That experience is going to be very, very important. And again, when I talk about the AA is useless if there are no data. So like EMR, if you don't put data, sometimes you may think this is useless data for me to make a decision today, but that may be the most important data if you want to really exploit the potential of AA. So don't neglect any data. Anything about the patient is suffering, whatever he had a fall, he had taken this, taken that surgery, everything should be there. Otherwise, you may not know what is really happening to or you may not get the full benefit out of the AA. So really a complete documentation of the patient is very important. A digital documentation of the anterior segment findings, posterior segment findings, and many other equipment, whatever that we are able to input into the EMR, we should do it. So that's a way, and again, giving the patient a good experience is also important. I really would like to thank all of you for coming in good numbers, staying all through this 1 hour, 15 minutes for this meeting. Thanks a lot.
Just to add to your question, I think the voice to text, which is getting really good now, at least there are now 3-4 different providers, they're brilliant. Whatever you say, it's there on your EMR. It filters off whatever is unnecessary also. It is so brilliant. Like let's say you're starting to talk in Hindi to somebody bringing you chai. It's not there. Okay? You're starting to talk in Telugu somewhere in between with somebody. It's not there. Whatever you're saying about eye, the cornea is clear, the lens MC, immature, cataract, PSCC, probably it's a PPC, I need to do an AIOS2025-IC489-Measuring, and then whatever you say is there on the EMR. I mean, that's the way AI is going. See, I think the problem with the EMR is how it is designed and how comfortable it is to use, and that is the big problem now, people. That is why we're not able to enforce, at least even in the doctor's level itself. In many places I've seen, finally they have a technician entering all the information from a paper. But somewhere you need to force them to use EMR, but with the AI technology, I think you can take it to the next level.
Even the Excel does a very good job. You don't have to have a professional EMR. Most of the things, in fact, a few years back, the 2020 resource from our side was based on Excel. It was pretty good.
Yeah.
It does 90% of the job what a professional EMR, which you will pay as a service or whatever, or you own it. Excel does it pretty well. We have to understand that EMR should complement us. I mean, it should not be that we are putting in data and not talking to the patient. Or your staff is putting the data and not talking to the patient. And as Arya sir said, that AI is going to come very close. So what is going to make a difference is experience or empathy or that human touch.
Thanks a lot. Thank you.
You can even make an EMR using Grok.
Yeah.
I went on Grok and I gave a prompt.
Yes.
Can you write a source code for an EMR? So it wrote that, a basic EMR. Then the next prompt I gave is, I'm a novice software developer, I don't know. Can you tell me how to implement it? It gave exactly all the steps which software to download, where to put this code that it has given. I did that and I found that I had a functioning EMR that I could use.
Correct.
The only thing is the interface for data entry, it says that you need somebody to create that interface, which makes it easier for you to, otherwise it's like a software, like an Excel sheet that you have to put.
Correct,
But
exactly.
I'm telling you that the way things are moving, a lot of things you can do even without knowing what to do.
True, true, true. So there won't be any difference between the first year resident joining the AIMS and Dr. Vananthi, There will not be any difference. So thanks a lot.